Welcome back. Months ago, as we started planning this event and landed on the theme of connected, the first person that came to my mind was Lisa Bari. And I am thrilled that she's here today to talk about her experiences and how she's guided Civitas from a fairly new and rebranded organization in bringing together HIEs, QIOs, RICs, all the APCDs, which I think is a fantastic opportunity for these organizations to come together and, in the theme of today, become connected in some way that's meaningful in their region, states, and otherwise. Lisa Bari is the founding Chief Executive Officer at Civitas Networks for Health, a national not-for-profit organization with a mission to support community and data-led health improvement and information exchange to address health outcomes and provide the infrastructure for health quality. Prior to Civitas, Lisa led as interim CEO at SHIC, the Strategic Health Information Exchange Collaborative, which is now Civitas Networks for Health. Prior to that, she worked at the CMS Innovation Center, working on primary care payment models. She holds an MBA from Purdue University and a master's in public health in health policy from Harvard T.H. Chan School of Public Health. I would like to add that not only has she brought many organizations together, her and her team have done an excellent job supporting local and national efforts. WISHIN is a proud Civitas member and thankful for the work her and her team have done, and a proud supporter of the regional host, we are going to be a host of the next Civitas conference next month in Detroit. So please join me in welcoming to the stage Lisa Bari.
All right. Well, I'm a little bit shorter than Steve. So hi, everyone. Lisa Bari. Thanks for the introduction and thanks for the invitation to speak to you today. I have a little bit of time with you here today, and I want to talk about the national landscape and what I think is relevant for folks working on this in Wisconsin. So just before we get started, please know that you can have all my slides. Apparently this is being recorded as well. It'll be on YouTube. So all of the above, there's a lot of materials here that I'm very happy to make available. And as you'll see, we have great membership coverage in Wisconsin. So there'll be more to say about that in a moment. So I already talked about me a little bit. I'll just say, as Steve noted, I'm the founding CEO of the organization. We created it about 3 years ago. We're coming up on our 3-year anniversary, bringing together two longer standing organizations, the Strategic Health Information Exchange Collaborative and also the Network for Regional Healthcare Improvement. So big, long names. They had hilarious acronyms, SHIC and ENRI. And so we've shortened that a little bit, and we are Civitas Networks for Health. I was working in the CMS Innovation Center before this, leading health IT and interoperability policy for those primary care and those ACO-like innovation models, and got really exposed to the world of HIE and health improvement collaboratives and CMS quality improvement organizations through that work with CMS. And then I was asked to step in as the interim CEO, and I suppose the rest is history. It's been a really interesting 3 years with this organization. We are national. We have 175 organizational members, and I'll talk more about that in a minute as well. I also serve today on the boards of the Zuria Foundation and the eHealth Exchange, which you may be familiar with if you're in the HIE space. So talking a little bit about Civitas. Our little tagline is regional innovation, national impact, which really represents what we do as a national organization with members who are themselves engaged in communities and states like the organizations here today. Our vision, what we're trying to achieve, is a world where communities are thriving and healthy, realizing the full potential of data-driven, multi-stakeholder, and cross-sector approaches to health information exchange and health and quality improvement in their communities. That's what we care about as an organization. We really serve as a member-driven organization, and then we also do sort of national programs and projects that bring together the work of our members. We also advocate on behalf of them at the national level. That means a variety of different things. For us, it's really about education and connection, reminding people in Washington and in state capitals that our members exist and that their work is really critically important. You probably all know how local healthcare is. You can have all the policies, all the laws, all the regulations you want, but at the end of the day, someone has to deliver care in person for the most part. And it really happens at that local level. And lots of things that matter at the local level matter for the successful care delivery and the delivery of high quality care and the moving of health data or health information. So we kind of serve to remind the folks at the national level, this is important and you can't just wash over it. It's different everywhere. People delivering care in person in their communities matters. So that's how we kind of exist. As Steve noted, we've got about 175 organizational members, and they cross a few different functional boundaries. They are the nation's regional and state and community health information exchanges. They are quality improvement organizations working for federal programs and also other programs locally. They are what we call regional health improvement collaboratives, which is like more of a catch-all term about doing that health improvement work and that public health work at the local level. They are data collaboratives. They are all-payer claims databases, and they're various affiliated and technology supporting organizations, which you'll hear about in a moment as well, who support the work of our members at the local level in different ways. And we're covering the entire country. So we have members in every state. Not every state has the same level of coverage, but every state has people doing important work in this area. And that's what we serve to sort of connect and do more of, hopefully. So I have a very complex slide. Don't worry about it. Like, you can see this in a smaller version or a larger version for you potentially. This really shows you again what I just said about the different types of organizations that we serve as Civitas. So on the outside in the dark blue, those are the types of member organizations that we have at Civitas. So data collaboratives and other related associations, our business and technology partners, the APCDs and other health data organizations and health data repositories, health information exchanges, and also community information exchanges, which is a growing space, as you may be aware, and lots of activity in the CIE space. Different types of regional and community health improvement organizations and quality improvement organizations. And then all of our members serve the folks at the point of care, at care delivery, doing public health activities, delivering on health insurance programs. So really the inside circle, half circle there is all of the people who Civitas' members serve in their own communities. So to give you an idea, we're really looking at this infrastructure layer across the country, if that means something to you. What is the infrastructure for healthcare delivery, for improvement, for information exchange, for ways that we improve the entire system? So that's us today. Again, we've been around for about 3 years, and we've grown significantly during that time. I think if you look at it from a broader point of view, maybe 10 years ago, there was really an idea that these local organizations wouldn't matter in 10 years, right? We would be doing, health information exchange at the national level. We'd be doing quality work at the national level from contractors who aren't really involved in your communities. And I think we can say pretty conclusively that we have proven them wrong. that in fact, these organizations have grown. They have certainly changed. They have updated the way that they work. A decade ago, health information exchanges, many of them built their own technology, for example. And that's starting to change over time as technology becomes more modular, best in class, using the same best in class services that for-profit companies use. But really, we've shown that having that connection to your community and actually being involved in the local infrastructure is really important. And I think people really expected that to change. And I'm not surprised that it didn't, but I'm happy to see the continued growth of Civitas and the awareness that you need those local connections to make this work happen. So one other kind of framing slide for what is Civitas. Our shorthand, this was more or less coined by Dr. Tom Evans from the Iowa Healthcare Collaborative, is that Civitas is the bridge between data and doing. So our members are somewhere on that bridge. They're the data side, they're the doing side, the improvement in healthcare, or they're on that bridge, they're crossing that bridge, they want to cross that bridge. All of those things are related to where our members are, who they are, what they do, bringing data into doing in healthcare. So just a little bit more there. And then in terms of what it looks like for us in Wisconsin, we actually have great representation as a member organization in Wisconsin. So WISHIN is obviously a member of Civitas, as is the Wisconsin Collaborative for Healthcare Quality. Gabrielle is right over there. And Metastar, Jesse is right over there. And then also a newer organization on the business and technology side is WellStack, who are also located primarily in the Madison area. And I will say that the WIO, the Health Data Organization, was previously a member of one of the predecessor organizations, ENRI, as well. So we, have had lots of representation in the past and hope to keep that going in the future. And I'll talk about why I think this is important in a moment as well. Also, just a shout out to the summit sponsors who are also Civitas members, Bamboo, Secure Exchange Solutions, Health Catalyst, and Medica. So you can see the kinds of folks who are involved in what we do at Civitas, who are involved in the work and supporting it and sort of agree with or find themselves aligned with that mission that we have of connecting data and doing in healthcare and really focusing on that importance of local infrastructure organizations. So that's a little bit about our coverage in Wisconsin. And then I should say personally, this is a little bit pandering, sorry, but 2 of my nieces are students at UW-Madison, so just adding it there. Looks like I got a little bit smushed there. So what I want to talk about, and one of the things that I think that Steve and the folks from WISHIN asked me to talk about was kind of, what is this looking like? Because if you step back, 3.5 years ago, we had this idea to bring together the HIE Association and the organization that represented the QIOs and the regional health improvement collaboratives. Why? Why did we do that? Because we saw that those worlds were starting to merge in different ways. Not specifically merge like the organizations, but the work was more and more connected. It's not enough to just move data. Why are you moving data? For health improvement, for quality improvement, for public health purposes? What is the reason? You heard Steve talk about moving to these important value-added services. It's not enough to just move the data. There are plenty of ways to move data these days. It's more about why are you doing it and how does it connect to your mission? And for quality improvement and health improvement purposes, you need better real-time data. The Wisconsin Collaborative Healthcare Quality, they have been doing data collaborative work for a long time. The quality improvement organizations like Metastar have been using data in different ways for a long time, but there are pressures to better connect that and use more and more real-time data to do that work, right? We're trying to move away from doing manual chart reviews, for example. We're trying to do, what else can we do to actually bring in more of that real-time data? And so there are many ways we saw these worlds merging and coming together, and we thought that was really important to bring the organization together and bring in all these players under one roof, so to speak. Now, to be fair, we are a very big tent. Organizations of, it's complicated. People have, different experiences, different backgrounds, but we are slowly and surely making the case for that collaboration. And so as an organization, we say, Well, we don't need you to merge. We don't need you to become one organization. We do want you to work together. We really want you to work together. Please try to find a way to work together. The good news is that in Wisconsin, you already have lots and lots of collaboration. People know each other. They serve on each other's boards. Probably some of you are neighbors. And really, that's the first step, right? Is just being connected. Now, what do we do from there? So I want to give you some examples of what this is looking like in other parts of the country. And this stuff has all happened since we launched Civitas. And so, some of it's related to us, some of it is timing. We got lucky, but they all are sort of part of that picture of how we're seeing these worlds collide between data organizations, health information exchanges, and health improvement and quality improvement organizations. And so I want to talk through a couple of them. So in Utah, big QIO organization, Comagin, they have a formal affiliation agreement with the Utah Health Information Network, WISHIN. And they've been working together for a long time, but they made it official, essentially. They've been working on advancing EHR adoption in their state and in the regions they cover. They have been working on cost transparency reporting, the capacity and the functioning of the all-payer claims database that Comagin manages. And this work is really going to serve to make them more streamlined, help them work together more. They just announced their formal affiliation, and they're still working out what it's actually going to look like, but they've really made that, they've taken it one step further to say, how can we truly combine forces in the value and the services we provide to people in Utah? So that's a big one that's been brewing for a long time. That's an HIE and a QIO partnership. In Ohio, there is a regional health improvement collaborative called now Health Impact Ohio. They do amazing work, especially around how they work with community health workers. And they're working on a variety of different platforms and services for them. And the now statewide health information exchange, OHIP or CliniSync, they've been serving on each other's boards for a long time and sort of sharing ideas. And now they are working on really advancing that collaboration with the community health workers, services, and data. So how do they get better data to community health workers in the actual community? So more there. That's an exciting one that's been brewing for a long time as well. There is also, so I'm from Northern California, and in my neck of the woods, Santa Cruz. There is a really promising regional health improvement collaborative and HIE partnership between the Health Improvement Partnership of Santa Cruz County and what is now called the Serving Communities Health Information Organization, which is the HIE in the Santa Cruz area. And they have been doing a lot of collaborative work on behavioral health and also various initiatives around the big Medicaid waiver in California called CalAIM. So they're supporting those connections really directly. Serve on each other's boards, work really closely together, try and find collaborative services opportunities together. We also have in West Virginia another QIO and HIE partnership between Quality Insights, which is the QIO that serves that state and with a couple different contracts, and also the West Virginia Health Information Network, which is pronounced the WIN and Quality Insights. They've also been working really collaboratively for a long time on behavioral health initiatives, probably unsurprisingly, around behavioral health and addiction treatment. And they have a particular type of certification for behavioral health providers that requires the advanced use of HIE. So the Quality Insights is working on making that happen for the behavioral health providers through their quality contracts. And part of that is ensuring that those behavioral health providers are appropriately and accurately using the HIE and, checking the PDMP and all the things that are involved in that. A couple more here. Oops, I moved on mine here. Back. Another QIO and HIE partnership, probably unsurprising, is in Wyoming with Mountain Pacific Quality Health, which is the QIO that serves that region pretty broadly. and the State Health Information Exchange, which is called Wi-Fi, the Wyoming Frontier Information Network. They also do collaborate on care management for Medicaid beneficiaries, Medicaid members, and they really focus on things, again, probably not surprising, around behavioral health screenings and performance management. So they have a technical platform that Mountain Pacific also uses in that case. And then finally, HIE and Regional Health Improvement Collaborative merger, an official merger. This one is special to me because the head of the HIE in the Buffalo area, Healthy Link, Dan Pareca, called me up very excitedly a few months after Civitas and said, guess what, Lisa, we're going to merge with our Regional Health Improvement Collaboratives, and we're doing it because of Civitas. So he was very clear to tell me that. But this was something that had been brewing for a long time. It was Healthy Link and the Population Health Collaborative, which was called P2 at the time. And they formally merged, affiliated, really to connect the HIE's data with the population health activities that population health collaborative partners were doing in the region, which they've been doing for a long time. So it was very exciting and was just another way to show how this can work. Again, we don't tell our members they need to merge or formally affiliate. We do say, you can partner on really interesting initiatives and they will be meaningful for your communities. Bringing together data and improvement activities is really powerful, and it's the way that we make progress in these areas and the way that we really show the strength of local partnerships and local organizations in doing this work. Because I think it's very, again, another important thing is we have to talk about it. We have to say what's happening because people don't pay attention to what's happening in local communities when they make policy decisions at the state level or the federal level. So talking about it and sharing about the successes of partnering locally is really important. So just a few details there on partnering on data to doing. I want to talk about the broader national landscape now. Wanted to make sure I covered this first because these are really important stories to share for you to think about how you can use data for quality and health improvement and how you can make sure that your moving your data is going to a really important purpose of improving healthcare outcomes for people in your community. But I want to give you a view now, briefly, of what it looks like at the national level. So, warning, here comes some really big slides that have lots of detail. You don't have to memorize them. They will be available. And there are also too many words to talk about. So, this is my example. Just to give you a view of the timeline, where we are. We're about 20 years in to health information exchange at the national level. And this shows you on a timeline various things that have happened since 2004. Of course, electronic health records, data-driven quality improvement, that started before that. But really when we started to say, okay, health information exchange on the timeline, it's about 20 years. And so lots of things have happened. The latest thing that happened at the national level was the renaming and the moving around of the federal agency that is in charge of looking at these HIE-like policies. It was previously called the Office of the National Coordinator for Health IT, and now it is the Assistant Secretary for Technology Policy and the Office of National Coordinator for Health IT, which that means is that they moved it up a little bit in the org chart at HHS, at the U.S. Department of Health and Human Services. And the idea is good. We'll see if it sticks. You all may be aware, because you live in Wisconsin, that we are in the middle of a presidential election year. And so things are likely to change with administration changes. And so we'll see if some of these things stick. But just to know where we are contextually, where we are in this timeline, we're about 20 years in. So not a super long time. I think I started in this field broadly in electronic health records in, I want to say, 2012, 2013. And so that's my view of this time. But before I started in this part of the world, a lot had already happened that was sort of setting the stage. And policy development continues. The now ASTP ONC has put out multiple proposed regulations this year alone. and many more in the preceding 3 years. It's a lot of policy, a lot of proposed regulations, a lot of new requirements. You all may know how difficult it is to incorporate new requirements, especially around technology, data standards, certification requirements. They have put a lot on the plates of people who are working in healthcare technology and healthcare infrastructure. When I worked in the federal government, I didn't truly understand how complex that is from an implementation level, and I really get it now. And I really empathize, and I think it's not going to hold. And that's because we can only do so much. You only have so much money. You only have so much time. And what you can hope for is that you have a local partner on the health data and the information exchange and the quality improvement side who can help you manage some of those requirements and be sort of the intermediary to sort those out for you. But there's a limit. And so this rate of progress that has happened in the last 4 years probably can't continue. I don't think so. And I also think a lot of things that have been finalized for future dates are unlikely to hold. So I want to just give you that context. 20 years, huge amount of regulatory action and work in the last 4 years. And I don't know that it will hold, and it's a lot for people in the healthcare delivery community to manage. Another point, again, we're not going to walk through all these. This is the history. You will have these slides. Feel free to look at them and marvel at the many policies that have been passed, starting with meaningful use. This is also to give you a view of what it looks like across the country, right? For more than 20 years, we've had HIE-like policies, whether they're state laws, regulations, whether they're executive orders about health information exchange. This happens everywhere. This is to give you a sense of there's a lot of stuff that's happened across the country at the state level. And now combine that as well with the previous slide with those 20 years of policies. It's a complex landscape. And I will also say, getting back a little bit to the sort of like government 101 stuff, it's very hard for the federal government to preempt all of this state law and state policy. The federal government, as you probably know, preempts state laws sometimes for very good reasons. Like the commerce policies say if something is interstate, then it can be preempted, but it's pretty limited actually. So if a state says, hey, we feel this way about health data, and here's what's really important to us, or this particular issue is important to us, like reproductive health data, for example, it's not that easy for the federal government to preempt it. So I also show this to our federal colleagues and say, okay, great idea, but you understand that there are laws in every state about health data and health information exchange. You can't just get rid of them overnight. That's a long process. So just to give you that sense. So in the context of 20 years of HIE policy, HIE laws, HIE regulations, and more than 20 years of state policy development, we have an initiative and a model and a framework that we've developed with Civitas members over the last couple of years that we call Health Data Utility. And so with that context, the emergence of health data utilities is what I want to talk about briefly today in the short time I have. So we define HDUs as regional or statewide entities that combine, enhance, and exchange electronic health data across different types of care and services settings for different types of use cases, including treatment, care coordination, quality improvement, public, community health, social care, whatever it might be. They really help us create this idea of health equity infrastructure in a particular state or region. And they have specific defined use cases, and they have an extra level of safeguards and privacy and protection for patient data. Importantly for us and important for Wisconsin, they build on existing technical, organizational, and trust infrastructure in states and regions. And because we don't have a lot of time, I'll just say, we don't have a specific mandate for health data utility. We do have lots of policy development at the national level. And we're also still working out, and every state and every community can work this out for themselves, what it looks like organizationally. Is one organization a health data utility? Is the health data utility a resource for a particular state or community that's built on partnerships and shared governance? All those things are open. So when I talk about this, keep your mind open there. Don't say it has to be one organization. It can be what serves your community, your state. And just to give you a brief sense, I will note we have resources on our website about this, which I'll point you to, what the characteristics are of these emerging health data utilities, just to give you a sense of what's important in a health data utility concept. First and foremost, neutrality and flexibility in meeting the goals of your stakeholders and your community partners, right? It doesn't work very well when it is a private company, a technology-only company. It needs to be a neutral convener of sorts. Needs to have designated authority for specific services, generally speaking. So whether it is moving some kind of data for Medicaid or for social services, having that sort of designated authority from a state or a community is really helpful in making it stick and making it sticky. Needs to have some kind of sustainable financing. These days, there's complex financing for this type of work, whether it is Medicaid matching dollars for technology, whether it is user fees, whether it is grants and contracts for services. Generally, having a mix of funding is really helpful versus being just based on user fees of any type. Needs to serve a connected region or state geography. We find this to be really important because you have to have that connection to the community that you serve. It's really, really important. Needs to have multi-stakeholder cross-sector participation. So not just providers, not just physicians, not just payers, not just technology, not just state, all of the above, patients, community members, business leaders. Having that multi-stakeholder cross-sector participation is really important for making it matter to your community. Why should you care? Because everybody's involved for a purpose. Should have modular infrastructure and advanced technical services. That's important, as I mentioned. Often a public-private partnership of some kind. Should have an inclusive governance strategy, open, transparent. We are not doing things in secret. We're doing it for all of us. And then really should leverage existing state and program, federal, state program data authority around how data are shared, whether it's HIPAA, whether it is public health data, whatever the state is allowed to do, they should let this organization do for everyone in the state. So really, that's like 2 seconds on HDU because we're running short on time, but there's more to say, and there are lots of resources on our site about this emerging model. Again, it is an emerging model. We're co-creating it with all of you and all of our members, so more to come there. Really quickly, I want to talk about the national networks and what's happening at the national level. You may have heard about national networks. You may have heard of the word TEFCA. And you probably heard of eHealth Exchange, Care Quality, Commonwealth. What about private networks? Epic has a massive private network in Share Everywhere, Care Everywhere, and they do a lot of interoperable exchange as well. Won't these issues be solved at the national level, and why not? Why do states, HIEs, local data collaboratives, and emerging health data utilities matter? And my answer is that look what's happening on the ground. Every year, the American Hospital Association does a big survey, and there's a supplement called the IT supplement. And their data shows us what's happening just at the hospital level. It's not everything. In terms of the percentage of acute care hospitals using state and regional HIEs, it's about flat at 79, 78%. And the percentage of acute care hospitals using national networks is also about flat, same decline that we saw here. That's a long period of time to not see growth in interoperability. That's on all of us, right? That's on the entire healthcare system. It's on the federal policymakers, state policymakers, on the AHA, on Civitas, and all of our members. When you look at this, you see that there are still more folks connected through state and regional HIEs And then there's many who are using both. 57% was the latest figure of hospitals who are using both national networks and local networks. Healthcare is complicated. There are many payers, many players, and it's not easy to find a one-stop solution. And I don't know if that's the right goal for us to point towards. And I think we should all really take a call to arms and say, you know, we still have progress stalled, right? We still have at least 14% who are using nothing, which is incredible. And there's a lot for us all to do to make that happen. To wrap that up, you know, I think if you look at, we believe at Civitas that community governance of health data is really important. If you look at the nationwide interoperability networks and frameworks, you would say that progress over the last couple of decades points towards consolidation, EHR-driven views of interoperability and data exchange, but still, community governance is really important of data. It has to be in line with state laws and preferences, local preferences. You can do both. You can have local exchange and also adherence to data standards and also on-ramps to nationwide networks and interoperability, but there's not one solution, and we need to have all of the above to get more interoperability, more exchange, more use of data for quality and health improvement activities. We are not there yet. We have not solved it yet. It is very much still happening, and we need more, not to cut different networks out. That's not where we are today. So, you know, this is our cute little slide here. Here's our sort of framing of it, is that national networks and frameworks are like the interstate highway system, and without those state and local networks, you'd be exiting I-90 onto a field, right? You need those local networks to make it happen, to get where you need to go, to get to that last mile and the last inch. And then, you know, we think, again, just to really nail it in here, we think the right equation is to have robust health data utilities across the country, covering every region and state in the nation, and high adoption of national networks and frameworks. And that will help us get to where we need to go as a country and improve our interoperability and our exchange. And then, as I mentioned, governance of HDUs, emerging, collaborative. We have more to do. We need to bring in the views of local communities, but the governance is overlapping. It's flexible. There's different ways different organizations we bring in, when, where, why, and how, multi-sector, multi-stakeholder, different geographies, different organizations. All those are involved in the emerging HDU model. So I'm going to skip ahead and just show you these are all available to you, give you some more examples, but we have a bunch of resources about this that you can look at. You can talk to WISHIN about, and you can talk to our other members here in Wisconsin and get their perspectives, how it applies to their work. We have a framework, we have a white paper sort of looking at it, we have some research from all the 50 states, and on our site, these are all available for you to look at. And then just one brief additional plug that Steve made. We are having our own conference. It's in Detroit this year. More of these topics, plus a bunch of great speakers and a lot of collaborative sessions, a lot of workshops to really get a better sense of how to implement this stuff in your own community and your own work. So hopefully you'll consider attending and joining us. As noted, our Wisconsin members are part of the host committee for the conference and will be helping us make it a reality. So that's what I've got for you. A little bit fast there. We have resources here. If there's time for one or two questions, I'm happy to take them. So if anyone wants to ask any questions or share anything about what I talked about, happy to cover it. Well, either way, thank you so much. Really hope that you take a look at the materials. Would love your feedback on the framework. If you take a look at it, how does it relate to your work? Does Gabrielle have a question? Oh, no. Uh-oh.
She's Gabrielle.
Thanks, Lisa. Yeah, I'm Gabrielle Rude from the Wisconsin Collaborative for Healthcare Quality, so a member of Civitas. But I wondered, Lisa, you mentioned that for the health data utilities that they be neutral, and then talked about, like, you know, it's for everyone. I wondered if you could talk about what kind of models you're seeing in terms of what stakeholders are at the tables in some other states.
Totally. So it really varies, as you might imagine. Some states have a big effort in their state government. Some of my colleagues are in Bismarck today, talking to the folks in North Dakota about what they're doing. And in North Dakota, they have a history of their HIE being part of state government. But it's very complicated because, as I noted, having that neutral perspective is really important. The way that those states tend to work is they have their HIE governance organization in a non-HHS part of state government. So like in North Dakota, it's part of basically the IT department. And that's how they kind of maintain their neutrality. So either you have neutrality because you are yourself a public-private partnership, a nonprofit organization with community governance, or you act like it as part of the state government. And then in terms of, how you're bringing in those other use cases, it can be through corporate board connections, like some of you have here, or it can be part of use case governance committees. So if you have a particular quality improvement use case or quality improvement services, you might have QI folks and providers who are part of that use case coordinating committee or governance committee, as it were. In Maryland, for example, there's a lot of public health activity between the state HIE CRISP and the state government and other folks working in public health. And they have a very specific public health governance structure that's separate from their corporate governance structure. So really, it just comes down to what are the use cases that are in effect in that state, and then how have they structured those collaborations or partnerships? And again, they can be as simple as we have a contract, we have an agreement, or it can be we have a sort of statutory role in the governance process on the governance committee or on the corporate board because of how we work together. So all those options are in place right now when you look across different states. But in terms of the home organization, when we started developing the health data utility model, a lot of historical HIEs were the home organizations, and now that's starting to change. Another example from here is in Illinois. Illinois has not had a statewide HIE for a long time. They really struggled. They had a couple of them failed. And now we see an effort that's starting from the public health and the CIE side. So we're seeing things spring up in different ways based on what the community needs and what the history was there, what that context was there. So I think we'll see more and more HDU-like efforts that start from different places, whether it's from public health and CIE or from QIO or from HIE. It just depends on what does the community need right now and how can we expand it to serve the broader goals of HDU over time. Any other questions? All right, so slides will be available for you. Feel free to reach out and ask questions. We'd love your feedback as a community on how the health data utility model can work for you. Would invite you on their behalf to speak to the Civitas member leaders in Wisconsin about how they're thinking about this, because it will only happen, it will only be a real thing if you all get involved and make it, what's relevant for you, what you need here in Wisconsin. All right, thank you.